So I think it's something where the panelists can, well, even the audience was able to text, chat before. I don't know what happened.
I just sent a message to everyone. Can you guys see it?
The audience, you mean?
Yes,
They can see it, but they can't respond.
Okay, I'm getting responses. It says
Okay,
it's open now.
I think I know what happened.
All right. Thank you to the team. Okay. Great. Oh my gosh, it's working again. Okay, thank goodness. I hope I wasn't the one that made it not work. Anyway, let's see. Okay, we have Amy Jones from Midland ISD. Thank you. Oh, it's working now. Yay. Okay.
Yay.
Chat is back. Yes. Okay. Alrighty. See, that's a good sign. All of our technology will work for the rest of the presentation, right? Ana De La Rosa from Child Crisis Center. Thank you for coming. And for anybody who needs continuing medical education, you can see how you do that. And actually they say that 10 days, but we have been getting so many people logging onto these sessions that we are behind in doing the certificates. So you might have to wait a few weeks to get your certificates. But if, let's say you're renewing your license soon and you need your transcript sooner, of your transcript of all the Texas Tech trainings you've done, just contact us, and then we can put you to the top of the list so you can get your credit for your to turn in for your license. Lori Connors, CPNP from Nacogdoches. All right, East Texas Community Health Center. Alma Cobos, El Paso Center for Children, TLP program. Awesome. Let's see, Laura Young asked if you're all muted. Yes, the audience is muted, but if you want to speak, then all you have to do is let me know through the chat and I can turn your voice on. You still have to unmute yourself, I think, but I can give you the permission for that. She says she just want to make sure. Yeah, I don't want my background noise to go on when I'm in one of these things either. If we Larry Llewellyn, Dio, I probably said it wrong, but wanted to know if attendance is automatically known if you log in by computer. Yes, I can tell yours is going to work because you have your full name there and you have that you're DO, so they'll know to get you the credit. All right, so we are 2 minutes after the hour. So again, this is the CME info, but let's go to the next slide. This is, of course, we are Texas Tech, El Paso. And today we have Dr. Jonathan Muniz, who is a PGY2 in the division of, he's working with the Division of Child and Adolescent Psychiatry for this presentation. We are hoping that eventually he will actually definitely be in the Division of Child and Adolescent Psychiatry and not just doing his training with us. So we are hopeful for the future. Jonathan has been a great student, both at the medical school and then as a resident. He's been such a great resident. We always appreciate him for his good humor, his dedication to his patients, and just for being a great team member. And I'm so glad that he was able to do this presentation today. Thank you so much, everyone, for joining us, and I will let him start.
And Lori, I'm gonna require a copy of this presentation just to hold Dr. Martin accountable for what she just said. So welcome everybody. Again, this is a presentation done by the Texas Tech University Science Center at El Paso, and we are part of the Division of Child and Adolescent Psychiatry. I'm Jonathan Muñiz, and I'll be talking to you today about bipolar disorder. So before I start talking to you guys, how many of you have a patient that is undergoing treatment for bipolar disorder? You can just type yes in the chat. That way I can see how many of you have experienced this. So I counted 11 responses so far. Wow. So that's a significant amount. So as you can see, bipolar disorder is fairly common. We see it in different sections, different places. Sorry. So the first question that we are gonna usual or often extreme and fluctuating changes in mood, energy, activity, and concentration. Where bipolar comes from. So before we start going on to diagnosing it, treating it, I want to go over what is not bipolar disorder, because those are things that you're always going to hear around, and when your patients come, they might actually tell you this stuff. And that's actually examples that I've seen in our services. One of them is somebody saying that está loquito, which is like the Mexican equivalent of saying, oh, that person is crazy. The other ones I've seen is saying, oh, my husband can never make up his mind. Sometimes he wants this, but then he doesn't. He doesn't want it. So how is this not bipolar disorder? The question that you need to ask as one minute I'm happy and the next one I'm sad. What the patient or yourself might be, you might be an adolescent bipolar. And that's how you thought that used to be around. People used to say, oh, if somebody had treatment resistant depression or they were requiring a lot of medication, that the person was actually had a diagnosis of bipolar. However, that's no longer true. We've seen some patients that are difficult to treat with depression, some patients that require a little bit more treatment. Something that is very important for us to know is that regardless of the situation, whichever patient comes to you, if they think they're crazy, if they think they're having issues, the most important thing is to be empathetic, because these people, if they have bipolar or not, they're still suffering some distress about what's going on in their lives. So we should try to empathize with them and see how we can help them better. Okay, so now let's start discussing bipolar and how can we diagnose it. So in order to know how to diagnose bipolar, we need to know what types of bipolar there are, right? So there are 4 types. One is bipolar disorder type 1. The other one is bipolar disorder type 2. Those are easy to remember because they have the same name. But then we start dealing with the other ones, such as cyclothymia or cyclothymic disorder. And we also have a bipolar specifier when we're not sure what's going on in the patient, but he's partially meeting criteria for bipolar. If you notice, none of these names include depression, but still be present. And I like to advise students to think of it this way. Depression is not what makes bipolar special. What makes bipolar special is a manic episode, because DSM-5 or diagnostic book tells us the patient should have at least one manic episode or hypomanic episode to be diagnosed. So this puts us into the next segue. What is a manic episode? Oh, obviously a manic episode is where you have mania. Mania is defined as a distinct episode of elevated mood, which is noted to be different than the normal happy of the patient. And it should involve at least 3 of the following symptoms, which is distractibility, excessive involvement in activities that have high potential for painful consequences, inflated self-esteem and grandiosity, flight of ideas or subjective experience that thoughts are racing, increasing goal-directed activity, decreased need for sleep, and more talkative than usual or pressure to keep talking. And actually, those 7 I actually just got them from DSM-5 because that's how DSM-5 defines them. However, in med school, where those who have practiced some little bit of psychiatry, we were taught on the morning to learn how to remember the symptoms of mania. Do you guys remember what the mnemonic is? Do you guys want to type it in the chat? Okay, so then the mnemonic that we learn in med school is actually DIGFAST, D-I-G-F-A-S-T. And if you see in this slide, we can translate DIGFAST to all of the DSM-5 criteria. And we can actually summarize them in simple words, such as distractibility, impulsivity, grandiosity, flight of ideas, activity increase, sleep need decrease, and pressure speech. So hoping that's going to help us remember the symptoms, we can start talking about them. So the first symptom that we're going to discuss is distractibility. And this symptom actually comes in different flavors. Basically, it's decreased attention to what's going on, and it's decreased attention or attention that is too easily drawn to not important or relevant stimuli. To provide you with an example, if a patient that has this distractibility in mania, they're talking to you, then suddenly a nurse walks through the door of the interview room. What do you think the patient is going to do? Well, there's several options. The patient might just switch his attention to the nurse completely and start talking about the nurse. The patient might just start addressing the nurse even though the nurse is not inside the room, or he might actually stand up and just start walking towards the patient because now his attention is focused on that new stimuli, which this actually we'll say, oh, distractibility is not that uncommon. We actually have other diagnoses that shows distractibility, which is actually a very common question. Do you guys can think of any diagnosis that has distractibility as the main diagnosis, as the main symptom? Yes, ADHD, perfect. So that's a common question we get. We have a parent that says, oh, my son has ADHD. Do you think he has bipolar? Does this mean he's going to develop bipolar? Well, it's actually kind of hard to say. A recent study showed that 17% of patients that are diagnosed with ADHD, they end up being diagnosed with bipolar. So in any setting, being primary care, being psychologists, being psychiatrists, if a patient shows up with ADHD and we have concerns of somebody being bipolar, we should ask ourselves, do a small screening and saying, is this distractibility episodic or is it every day? If it's episodic, well, that's pointing a little bit more towards mania. Well, if it's every day, if it's their baseline, that most likely is ADHD. And also, is this distractibility accompanied by a change in mood? Remember, we have to take it into the context that this person is developing a new mood, it's an elated mood. And again, if both of those questions are no, then most likely the person has ADHD. Okay, so the next symptom that we're going to discuss is defined as DSM-5 as excessive involvement in activities that have high potential for painful consequences. Personally, I think those big sentences can be summarized into words. Sorry, just to answer one of the questions, Carolyn Carlson, the most recent study that I found says 17% of patients with ADHD end up diagnosed as bipolar. And going back to the symptom, the excessive involvement in activities that are high-risk activities. So I say we can define them as impulsivity or irresponsibility. And I think the reason those words are appropriate is because patients that are undergoing manic episodes can develop behaviors that are not usually socially accepted or socially considered normal, because are those the high-risk activities. For example, some of the patients that are going on a manic episode can start developing behaviors such as gambling, getting into fights. Other patients we've seen, they start engaging in prostitution or doing drugs. And this is a very, very important symptom because we need to make sure that we're not seeing a person that is doing those activities as their baseline, or we're seeing a person that is doing these activities because they're in a manic state. If you check look out for a recent article that shows that around 56% of patients with bipolar disorder have experience using drugs, and 46% of patients with bipolar disorder use alcohol as well. So if you see there's an overlap, so we gotta be careful, but it's one of the symptoms that we can consider. If the patient is going through a manic episode, he's gonna have high risk taking activities. Again, if somebody is doing these activities, do not label them as bipolar. Start considering what type of help can I give to this person. Okay, so now let's talk about the third symptom, which is inflated self-esteem or grandiosity. Some patients are going to explain it to you as feeling on top of the world. That's actually why when we learn the criteria for mania, we ask that question to the patient, oh, have you had this feeling of being on top of the world? And that's an amazing feeling. However, this feeling is not just feeling too happy or like we can achieve anything. It expands into different realms. But to give you some examples, I find people that said, oh, I'm a prophet. Or other people say, I have found a way to cure world hunger. And if you see those a little bit elevated, but they're still possible, right? So whenever somebody's showing with a grandiosity that's still possible, we need to make sure to take it into context. So for example, those who were raised in the Christian religion, Christianity calls you to be a prophet. So if somebody that is Christian tells you, oh, I'm called to be a prophet, could be, could not be grandiosity. However, grandiosity also presents in less elated ways. So for example, I've seen patients tell me that, oh, they're writers and they've written thousands of books. So you need to do a little bit of in-depth questioning in order to diagnose if this is actual grandiosity or is this person actually telling you the truth that they have these achievements. So remember, for grandiosity, it's important to take into consideration cultural background. I was talking to some of the med students about this. It's very different grandiosity here in the United States. There's going to be grandiosity in Asia and Europe. So we always got to be careful what the cultural background of our patient is. Okay, so the following symptom about patients undergoing a manic episode is about the way they're thinking, and it's usually called flight of ideas. Do any of you know what flight of ideas is when we talk about that? Has any of you experienced that with a patient? Okay, so some of you have seen it. And when somebody's showing flight of ideas, it's kind of hard to follow what they're saying. I actually had one student that I think it was really funny that they told me, well, how can you evaluate their thought process, their flight of ideas, if we cannot read minds? I told them it's actually a very simple task. The thing is just listen to the patient and then ask yourself, is what the person telling you making sense, or is he jumping topic from topic to another topic? If he's doing jumping from topic to another topic, are those topics related? Because flight of ideas is defined as when someone is jumping from topic to topic, but those topics are related. So I actually have a little exercise of thought process that I would like to run with you, just for you to see how flight of ideas looks like. So start thinking of this way. If I'm gonna ask you, if you're in the 6th floor, how are you going to get to the cafeteria in the basement? Well, one option to answer this question is, well, I'm on the 6th floor, so I can take the stairs down, then I'll take it to the 1st floor, then I'll switch stairs, then I'll take one stairs floor down, and that's gonna take me to the basement. When I take a right, and I'm gonna be at the cafeteria. Then another option to answer this question is, well, I'm in the 6th floor, so I'm going to take the stairs down because I like exercising and I'm trying to lose weight. But once I reach the 1st floor, I need to take the other stairs to the basement. Finally, I will walk down the hall, take a ride, and I'll be at the cafeteria, which is serving tacos today. Then another way to answer this question would be, well, I'm on the 6th floor, so I'm going to take the stairs because that is good for your heart. Valentine's symbol is the heart. Hearts are symbol used for Valentine's Day. On February, days are pretty cold. If you see this last person is not answering your question, they are switching topics. But if we start thinking about it, those topics are kind of related. That is what flight of ideas is going to look like. It's going to be switching topics, but you can see where the previous topic is coming from. While the other two answers, answer A and B, are answering your question. The first one is giving you the simple steps and it's giving you the simple answers, while the other ones are putting a little bit more information, but still answering your question. Answer A is what we will consider logical, goal-oriented, while answer B is going to be what we call circumstantial. And I know that was a very long symptom to talk about. So let me just go back a little bit. Let me remind you that we're talking about bipolar disorder. We're talking about mania. And we have gone over 4 symptoms: distractibility, impulsivity, grandiosity, and flight of ideas. Okay. So just reading from the chat, one of the interesting comments from Tina Houset: my client goes from one thing to another in about 5 seconds with 5 different things. My question will be, at the end, does this person answer your question? Again, because that's what's important to differentiate between circumstantiality to flight of ideas. Okay, so moving on to our fourth symptom is going to be an increased activity, an increase in goal-directed activity. And some of the examples that we've seen is some people start painting their house, they start cleaning the kitchen, they start washing the car, and they start baking cakes. And if they're able to finish those tasks versus if they keep initiating one task and moving to the other, that's going to help us differentiate between bipolar type 1 and bipolar type 2. And just to tell you an anecdote, it's also how bizarre are they doing those behaviors. I've seen patients that, for example, they start baking cakes. Oh, well, baking cakes is not as abnormal, right? Some of us like to do that. However, some patients have told me that, oh yeah, I start baking cakes one after the other. I bake 20 cakes in a single day. They're not, they don't work for as a in a pastry store. They're actually just doing it because they want to be cooking. Other people have told me they start baking cakes at 3 a.m. and then they start to deliver them to their neighbors. So you start seeing how these behaviors, even though they sound normal, they can start still be very, become a little bit bizarre. Our next symptom is going to be a decreased need of sleep. And this symptom is a very common complaint from patients. So we always got to be careful what the patient is actually telling us. So my suggestions when somebody comes and complains about the about decreased sleep is first ask, how is your sleep? Do they feel like they're sleeping a little bit, sleeping too much, not sleeping enough? And how many hours? Because all of us have seen that, right? All of us have slept 10 hours and still feel very tired. So make sure that you first cover the basics of your sleep needs. And then if the patient tells you, oh, okay, I'm sleeping less than normal. Usually somebody that is going into a manic phase, they're going to be sleeping very little. We've seen patients sleep around 3 hours, 2 hours. We've seen patients sleep 0 hours at all. So at that point, you ask the patient, why are you sleeping so little? Maybe the patient is going through a stressful situation and they're anxious. Maybe the patient is drinking coffee at 10 p.m. and he's not sleeping, or maybe he's watching TV at night. And then the final question, you will ask them, are you tired through the day? Because that's going to help you differentiate most between somebody that is not sleeping well, between somebody that has a decreased need of sleep. If he's able to sleep 3 hours and then have a lot of energy through the day, well, that's pointing more towards a manic episode. And as I stated here, manic episode will have minimal sleep with energy feeling through the day without help of stimulants or naps. So also we gotta be careful with that because some patients use other things to stay awake. Okay, our final symptom is a symptom that is very easily noticed, but that's also very easily confused by other people, because the definition that DSM-5 asks us is a more talkative than usual or pressure to keep talking. And this symptom is assessed through the whole conversation. Don't focus just towards the end. Think about it as the whole conversation. Is the patient speaking more than usual? It helps if you know the patient. If this patient is usually more contrite, he usually just answers questions in 2-word sentences or a little bit longer sentences, and suddenly this patient is giving you non-stop answers if he's telling you a full story when he usually just gives you small things. That is what is called verbose speech, using more words than needed. However, some patients also develop what is called pressure speech, which is a speech that is uninterruptible and continuous. And once you see a patient that has pressure speech, you'll start learning to identify it. Because these patients are just keep talking. You cannot jump and interject. They're just gonna keep talking and they're not gonna stop at any point unless you actually force them to stop. So I actually was thinking of an example because again, this symptom can be confused very easily with just excitement. So for example, I have one patient that he's usually very contrite, very calm. He doesn't like to speak a lot. But then we started talking about his favorite video game. And then he started going about it, going in long sentences, telling me a lot of information about it. And that was actually not his usual. But then when we went back to the other topics that we're talking about, his house, about his education, then he started giving me his usual 3-word answers, 2-word answers. So always we gotta be careful that the patient is just not excited about what's going on in his life. Okay, last time that I'm reviewing this for you. So again, mania is a distinct episode of elated mood, inflated mood, and it has to have it comes with 7 symptoms: DIGFAS, distractibility, impulsivity, grandiosity, flight of ideas, increase in goal-oriented activity, decreased need for sleep, and more talkative than usual or pressure speech. However, not all the symptoms need to be present for somebody to be diagnosed with a manic episode. You actually need 3 or 4 symptoms, and it's gonna depend on how the patient's mood is, what the patient's temperament is. If the patient is usually nice and calm, well, you only need 3. But if the patient is usually irritable, if the patient is usually aggressive, then you're gonna require to have 4 in order to be able to diagnose mania. Before going to the next slide, thankfully, something that makes our job easier as a psychiatrist is that a lot of patients show with several symptoms. However, DSM-5, in order to avoid misdiagnosing it, those requires with 2 other conditions. The first one is must not have any other explanation, because a lot of things can mimic mania. And actually, ICD-10 came out with some diagnoses that said mania secondary to this. Some of the examples that we've seen, somebody that looks like they're going through a manic episode, have been hyperthyroidism, people using methamphetamines, they're going to look like they're going into a manic state, or people are even with steroids. We've seen patients that are going treatment for their Addison's, for other diseases, receiving steroids, and they start becoming in a manic state. So by DSM-5 definition, they might be in a manic state. However, it's not considered a bipolar disorder. And again, thankfully, ICD-10 gave us some alternative diagnosis where we can use this part of it. So for example, we can have a manic state secondary to methamphetamines. Then the other condition that DSM-5 requires us is impairment in social functioning or to necessitate hospitalization to prevent harm to self or others, or if there are psychotic features. So, and this is true for any psychiatric diagnosis. The patients need to have some type of dysfunction. Dysfunction can be very broadly defined. Some patients are not able to work, and some patients are not able to finish their work. Some patients, as I said before, because of the high risk taking activities, they start getting into drugs, they start getting into fights. So always look for this type of social dysfunction in the patient. And automatically, if this patient has requires a hospitalization, he falls into the bipolar disorder, or if they start developing psychotic features. Okay, so one of the questions that you're gonna see quite often is, why do we treat bipolar disorder? And this is a fair question that patients are gonna have. So I will advise you to put yourself in the patient's shoes. Think about it. If you're having this grandiosity feeling, if you think you can achieve anything that you want, and you, on top of that, you have increased energy to do it, that is an amazing feeling, right? I wish all of us could feel that way, because that was going to help us to get through our day really easily. However, this grandiosity, this manic episode do come with some costs. There are several famous people that have been diagnosed with bipolar disorder. One of my favorite testimonies comes from actor Stephen Fry. He has said in several of his interviews how he lived his life before being diagnosed with bipolar, and then after he got diagnosed, how he started handling. And one of the things that caught my attention is he said, you can harness the energy into creative purposes. He actually mentioned that he used to be able to write plays while he was going through a manic episode. And so he loved being in a manic episode. However, as he kept growing up and started seeing the other side of the coin, he started noticing it was costing him more than it was worth it. So for example, he stated at one point, I don't think I have written a poem when depressed. And if you're more interested in seeing his interviews, the two interviews that I would recommend is one that he called "What I Would Tell My Younger Self," and the other one is actually a documentary by the BBC, which is called "The Secret Life of a Manic Depression." And for us as mental health providers or as providers, we need to advise our patients why are we treating bipolar, and again, it comes with a cost. One of the most significant one is that patients having a bipolar disorder are at higher risk of suicide. 1 in 3 patients with bipolar disorder will attempt suicide in their lifetime. The other thing that you can tell your patient, and they are most likely have experienced it, the depressed state is not enjoyable. They are most likely remembering their manic state, or they are remember the feeling of being manic. However, in a depressed state, they're not gonna be feeling that way. They're gonna completely be the opposite. So they're not gonna be enjoying it. For us, as we start addressing the mental health needs, we need to consider also bipolar disorder is considered the 12th most common disabling condition for any age group. And this comes with another thing, as I was mentioning before, the risk-taking activities. Patients are going to become very dysfunctional because of this. Moreover, thinking in the long term, patients have started burning out their brain. What does this mean? Patients that have bipolar disorder increases their odds of having dementia at a younger age. So another question that patients are going to start asking you about from this is, well, if you want to treat it, why does it happen? How do we know how to treat it? In reality, it comes from different things. And as you have experience, most likely experience, any psychiatric disorder, we divide them into a biopsychosocial formulation because we can see their input in 3 different sections. So for example, in biology, we actually used to say the monoamine theory, right? We used to say that patients with schizophrenia have issues with dopamine, patients with depression has issues with serotonin. However, we have noticed that there's more of a interaction between multiple neurotransmitters. So at this point, we're developing new medications that hit different neurotransmitters. However, we also notice that patients have a genetic predisposition. Patients that have a bipolar disorder, they're most likely to have a kid that has bipolar disorder. And actually, if somebody has a sibling that has bipolar disorder, there's a high chance that they're actually going to be also diagnosed with bipolar disorder at one point in their life. Other things that cause bipolar disorder from a psychology perspective is childhood abuse trauma. This causes a mood dysregulation and is very common to see in patients that have bipolar disorder. Stressful situations like losing a job or death in a family can trigger mania. And this is actually something that you'll see. Patients are going through a stressful situation and suddenly they have the first manic episode, or they stop taking the medication, which end up being in their manic episode. Also is the stigma of being diagnosed with a disorder, the denial about being sick, not looking care. That's gonna start impacting how they take care of their disease, and it's gonna make it harder for them to receive treatment. Again, it comes with a social aspect. It's gonna cause social impairment. And also things that are gonna worsen or impact their bipolar disorder and negative life events, life-threatening illness in a family member or interpersonal stress. I mentioned before in the psychology section, losing a job, your stress at work can also impact their bipolar disorder. So the next question, okay, we know why we should treat it. We have an idea how is it why is it happening. So how do we treat it? The treatment can be very varied. Sometimes we use lithium, or we use the class of medications called mood stabilizers. The main mood stabilizers that we use are lithium, valproic acid, carbamazepine, oxcarbazepine, and lamotrigine, 5 of them. However, we can also use antipsychotics. And the most commonly used antipsychotics include olanzapine, quetiapine, aripiprazole, and risperidone. Okay, and one of the questions that your patients are gonna ask you is, which medication is the best? Which medication should I take? In reality, all of these medications are valid and they work for different things in different patients. So patients start even responding better to our medication, and suddenly they need to be switched to a different medication. So patients that are in an inpatient setting are going to respond more to a medication, but once they go to an outpatient setting, they're going to switch to a different medication. So this is a thing that you need to sit down with your patient and talk about the pros and cons of each medication. And remember, if at any point you don't feel secure taking care of this patient, if you need some assistance, this is the point where you will start involving or psychiatrists or mental health providers. Okay, so we mentioned that this disease has depressive phases, right? It used to be called manic depression. So what about antidepressants? Well, we're taught in med school to not use antidepressants for this population because it can put them into a hypomanic or a manic state. And actually, monotherapy with antidepressants, particularly with SSRIs, is contraindicated in patients with mania. However, if the patient is in a mood stabilizer and the patient has had proper treatment with a mood stabilizer, we can start considering using antidepressants if their depression is very severe or they're having difficulties getting through that depressed phase. Any antidepressant can be used in reality. However, the most commonly used are fluoxetine, sertraline, and bupropion. Particularly fluoxetine is becoming more popular. Now there's a new medication that combines olanzapine and fluoxetine. So you're gonna provide the mood stabilizer and the antidepressant phase. And if at any point you don't know how to progress in the treatment, this is a good time to refer to psychiatry. So as PCPs or as any provider that you are, if you're taking care of a patient, what you should know of the medication, what should you be taking care of regarding these medications? Well, the first thing I would say is there's 3 medications you want to check levels if the patient has had a change of medication. And most likely if the psychiatrist is taking care of it, they're going to recommend these labs. But if they're not, I think it would be appropriate for you to do it. So for example, if somebody had a recent change in their lithium, we can recommend a lithium level. I put in the numbers there if you want to learn what is the appropriate treatment dose. Also for valproic acid and carbamazepine. If any changes in medication happens, we can check a level usually around 4 to 5 days later. Besides the medication levels, there's also labs that we want to check either yearly or at least at baseline to know what was going on. So for example, we want to check a CVC because some of these medications can cause agranulocytosis, thrombocytopenia, or even anemia. But we also want to check CMP because we want to check that all the electrolytes are normal. And I will advise you to actually keep an eye on sodium because some of our medications can cause hyponatremia. Also check a lipid panel because most of our medications predispose the patient to gain some weight and actually predisposes them to metabolic syndrome. We also want to measure TSH because some medications can impact TSH and also to make sure that their symptoms are not related to a thyroid problem. The other thing that you want to consider ordering yearly at least is an EKG because we want to make sure that these medications are not impacting their heart. If you have a patient that has female reproductive organs and they're at a reproductive age, you want to make sure that they're not pregnant before you initiate or continue any of these medications. However, some patients do require to be on this medication while going through pregnancy. So at that point, it's very important to talk about the patient about the benefits and risks. And if you have any doubts, again, consider referring them to the psychiatrist. And as people that were dealing with pregnancy and possible consequences of medication on pregnancy, it's very important that we learn to advise the patient about the contraception. And the patient is going to take the ultimate decision. But if the patient is going to require something like, for example, valproic acid, which can cause neural tube defects, we need to advise them that it would be preferable if they're in some type of contraception. The other lab that I would recommend you is liver function test because we want to make sure that AST, ALT are at appropriate levels before we start some medications. And finally, particularly if you're using antipsychotics, we want to make sure that their prolactin levels are not elevated. So the take-home points for people that are handling patients with bipolar disorder, particularly those who are primary care physicians. First of all, bipolar can be very disabling. Second, 1 in 3 patients will attempt suicide. So that's why it's very important to look for this disease, to screen for this disease. When we have concerns that somebody is going through a manic episode, remember to think of DIGFAS or mnemonic for diagnosis. And remember, you need 3 or 4 symptoms depending how the patient is exhibiting. Remember, if you're already treating a patient that has bipolar disorder, those patients are at high risk of diabetes type 2, obesity, and cardiovascular disease. As I stated before, some of our medications can be teratogenic. It can cause impact pregnancy and the product of pregnancy. So always advise about contraception. The main treatment for mania and bipolar disorder are mood stabilizers and antipsychotics. However, we can sometimes use SSRIs if the patient is severe. And never forget, monotherapy with SSRIs is contraindicated in bipolar disorder. And learn to find the warning signs of mood relapse, of mania. The patient is going to start complaining of the sleep disturbance, of agitation, and increased goal-oriented activity. And let's actually talk about, let's say you are in your clinic and a patient comes to you and they're in a manic state. If you have concerns, try to learn what your mental health authority does. So mental health authorities have contracts with 911 for them to dispatch somebody to assess the patient. And if you're having concerns or you cannot reach them, send this patient to the emergency room or contact a psychiatrist for them to advise you how to handle this manic patient at that point. Now, before we finish this presentation, as I mentioned before, some patients do discontinue their medication. And there's several reasons why they discontinue the medication. One of them is the weight gain, because these medications, most of them are going to predispose you to a weight gain and metabolic syndrome. And what can you do about it? You start advising the patient to switch their diet, to start exercising, and now standard of care is becoming to actually initiate metformin if you are initiating one of the second generation antipsychotics, because it's going to help them to not get diabetes and also to control their weight. Another reason patients discontinue their medication is because those medications tend to cause some type of somnolence. So those medications, if the patient can get through the day, we advise them to take them at night. Unfortunately, one of the main reasons patients discontinue their medication is because they end up in a depressed state. And when the patient starts complaining about it, start making sure that the patient is not actually just missing the mania. They're disregarding the depression because they remember the mania. And if they're actually dealing with the depression, it might be a time to switch to another medication that will also help in treating the depression. And also, the most common reason to discontinue any medication for any illness is tiresome, to be monitoring the disease, and also to be taking medication on a daily basis, because most of these patients are going to, these patients are going to take medication for a lifetime. Okay, one more time, DIGFAS for mania, and you need 3 or 4 symptoms. One last thing, how long have patients been manic? There's some minimum that the DSM-5 asks for, at least 7 days for type 1 and at least 4 days for type 2. However, there's no maximum for how long a patient can be manic. I've seen patients that are manic for just days. I've seen patients that are manic for weeks, and I've seen patients that are manic for months. One of the things that comes up with trying to differentiate if the patient has any other diagnosis is, can a manic episode last minutes? Not really. Patients might experience some euthymia for minutes, but the requirement is that they stay in a manic state for most of the day. So what happens if your patient is telling you that he does manic for a couple of minutes and then he's fine? At that point, you should consider a different diagnosis than bipolar disorder. And again, when in doubt, refer them to psychiatry at that point. And that is bipolar disorder. That's my whole presentation. You should be experts on how to diagnose it and how to handle this disease at this point. And again, I want to finish this presentation reminding you that regardless of the diagnosis, these patients are patients that have a disease. So we should treat them like people instead of saying, oh, he's just bipolar. No, this is a patient that's suffering from bipolar disorder, and they deserve our empathy. Okay, well, thank you so much for listening. Any questions?
Hi, Jonathan. Thank you so much. That was great. It was a great review, great presentation. Let's see. We did have a question from the audience. Could you treat a patient with natural herbs, or do you know any cases of patients being treated by natural remedies? I answered this directly to the person who asked it, but I know that I definitely have had patients who have tried this. and have been unsuccessful. Bipolar disorder is a very serious illness, and even with medications, patients have sometimes have manic episodes and depressed episodes. It's a very difficult disorder to reduce the symptoms. So, you know, maybe what we would recommend as psychiatrists and child psychiatrists is go ahead and add natural remedies, especially if you consider psychotherapy a natural remedy, add it to the treatment. But in terms of, we wouldn't advocate if we are absolutely sure of the diagnosis for just doing an herbal remedy. There just aren't any studies that I know of, at least, that show a strong enough that are strong enough to prevent a manic episode from happening. And a manic episode really can ruin somebody's career, relationships. It's a very serious thing. So let's see, there's another one. Jonathan, I'll let you take this one. The difference between bipolar type 1 and schizoaffective disorder.
So that's actually a common question that we get when we're meeting patients to the hospital. Is this patient actually schizoaffective or bipolar? So the main thing is think about the mood disorder. And as I mentioned before, a patient that is going through a manic episode has to have these abrupt changes in mood. However, a patient that has a schizoaffective disorder is going to have two types of episodes. One is going to be a psychotic episode and a bipolar episode. And during this psychotic episode, the patient is not going to have any mood symptoms. He's going to be at his normal, his baseline mood. One of the other things that you can think of, this is not 100% true, but it's going to help you differentiate. Patients that are in a bipolar episode that have psychotic features are going to have mood congruent psychosis. This mood congruent psychosis meaning they're going to try to embellish the grandiosity that they're having at that point. However, patients that are going a psychotic episode of schizoaffective are going to have their most bizarre psychosis, not mood congruent psychosis. They're going to think that people are poisoning their food. They're going to think that somebody is walking under the roof, and they're going to be hearing voices just talking to them. So that's going to help you differentiate if the psychosis with is mood congruent or non mood congruent. I hope that makes sense.
And then let's see, another question. What is the youngest age that a person can be diagnosed with bipolar disorder? I can answer that one since I'm a child psychiatrist, but hopefully Jonathan will in the future be a child psychiatrist. That's what we're hoping. But anyway, the youngest age, there is no youngest age, but it's very, very rare to have bipolar disorder start before puberty. And in general, it is comes in mid to late adolescence, and even more often in young adulthood. So you might, looking back, when you have a patient who has who now meets criteria for bipolar disorder, you might look back and they had some emotional problems in the past, some symptoms in the past. But usually they don't meet full criteria until after puberty and into adolescence. And this is true for many disorders, by no means all psychiatric disorders, but many, such as schizophrenia. You're more likely to be depressed if you're a girl after adolescence. So for those three disorders, there are differences, quite a few differences between pre-pubertal children and adolescents and young adults. Let's see, there's another question. Where can we learn strategies to help people with bipolar that are seriously ill? Oh, goodness. One of the best supportive agencies that I've seen in terms of if you're not a doctor and you want to help people that you either work with or people in your family is NAMI, and that's the National Alliance for the Mentally Ill. And it's an organization especially designed to support and educate people who have people with mental illness that are in their lives. So people, like if you have a client, but you're not a doctor and you're not a therapist, that might be a good place to start. They have a lot of resources. And then they also have groups, educational groups, as well as support groups for families. Let's see, any other questions? Did I miss any? I think that's it. No, wait, we got another message. Let me see.
There's
What
a
about for
Q&A.
therapists? Oh, for therapists, I don't know. I mean, I think your professional organization is probably the best place to start. Usually there's like for us, we have the American Psychiatric Association. And when I go to our conference, a lot of times that's the sort of education that we get, stuff that we don't necessarily get while we're, it's not on the test and it's not in the book type of stuff. Sometimes it's at a conference. What were you going to say, Jonathan? Did you have a suggestion for therapists?
No, I was going to mention there's also a Q&A.
Oh, okay. All right. Can you please describe the differences for childhood bipolar compared to adults? So there is not that much difference. There's not that much difference. In order to definitely be diagnosed with bipolar disorder, you have to meet just the same criteria that you would in an adult. And you're going to see very similar symptoms, but they might, like their delusions and their grandiosity will be age appropriate, such as for an older person, it might have to do with something to do with their work. For instance, I had a patient who gave himself a promotion at his work, and that was his form of grandiosity. He thought he was smart enough and he should be able to give himself his own promotion instead of waiting for the promotion date and going through the promotion process. And so he just put the rank on his uniform and went about his business. Whereas a child might go and tell the teacher that, well, they really are the smartest kid in the school and they don't know why they even have to go to school still. So those are the types of differences. And then Carolyn Carlson also asked a question about a similar question, DMDD versus bipolar disorder. DMDD is not episodic. It is chronic irritability, whereas bipolar disorder is episodic. So a lot of the symptoms are the same, although you do not have psychotic symptoms either in a patient that has DMDD. It is irritability and outbursts, which you can have in bipolar disorder, definitely, but not in an episodic pattern. It's a patient who has DMDD has, at least to meet criteria, you have to have at least 3 outbursts a week that are inappropriate for the age. So, like a high school student, all of a sudden, throwing things around in the classroom. Well, but with no grandiosity, no euphoric mood, no differences in sleep, and that sort of thing. So, but the one of the best ways to tell the difference is that it's not, if it's episodic and it goes for weeks as mania and then weeks of depression, that's how you can tell the difference. Oh, we got a nice thank you for you, a long one from a UTEP student. That's great. Thanks so much for coming. We're getting lots of thanks, but thank you all for coming. We really appreciate it. And, when you do have, oh, and there's the survey to receive your credit. So if you all could click on that in the chat, that would be great. And then also when you have questions about specific patients, please call us. And I think the number is on this one right here, right? Oh, wait, do we have the number? You know what? I can't see the number on my screen, so because it's at the very bottom. So I don't know if you guys, you all can. I'll put it in the chat here. But it's the same number for all of Texas. And then also, oh wait, there, Joyce put it in there in the chat. So the number is 888-901-2726. And then because it's for all of Texas, you have to push option 4 and then option 2. And then if any of your patients need an in-person visit, actually we do telemedicine now. We have a telemedicine program also through the same funding that we have for CPAN. And the telemedicine visit is through the school. And so, but also you can call us, and if your patient needs an in-person visit, we will tell you the best place to go to take that patient. And so give the same number, give a call to the same number if your patient needs, if you're a patient or a student or whatever the case may be, client. I know we have all different kinds of professions in the audience. Give us a call and we can help you get an in-person appointment in an area that's close to your patient's own house or school. Let's see, do we have more? Oh, Dr. Llewellyn, see, I said it right this time, I think. Didn't see anything in the survey about a chat. I mean, a chat about a survey. Maybe if you, Raul, if you could put the survey in the answering, maybe people can, and the question and answer module, maybe we can click on it from there. And let's see. Oh, and so someone asked a technical question about credit. You work at a school district and many of the questions on the survey do not apply. And that's fine. You could just say do not apply, and then you'll still get your does not apply or NA or something like that. And then you'll still get a certificate. Anyone who's not either an NP, a PA, a DO, or an MD, they'll get a certificate of attendance. And of course, everyone else will get the official AMA Category 1 credit. Let's see. Just a lot of thanks for your presentation, Jonathan. Those are the comments we have. And then, oh, it says I did respond NA and not applicable, and I could not proceed. We will try to figure that out. Sorry about that. I'm not sure. But I think you'll still, I think that the survey is more for people who need the official AMA credit. And so you'll probably will still get your certificate of attendance, but I will look into that. And maybe we can just have a different survey for people who are not trying to get the AMA credit. Oh, and there's Dr. Llewellyn, Raul put the survey in again. And then also after this, because you probably logged in with an email address, we can also send that to you after this is over. And then I know a lot of people always ask me if we can, if their colleagues that can't come live at this time, they want to see the presentations we have. And we have a YouTube channel too. So you can just put in Texas Tech El Paso YouTube channel, and then you can see the different offerings. We also, I think, do we have that link on our website yet? I don't know. We're always updating tons of stuff on our website all the time, but thanks so much everybody for coming. I'm glad everybody is so interested in this topic, and I really appreciate you all coming. And we hope that you also let us help you on an individual basis by calling our CPAN line so you can have an individual consultation on your patient. Alrighty, thanks so much. And you know what, I love to see we get a lot of the same people week after week, and we're so glad to see you all. And because to me that means you're finding it useful, and we don't want to waste your time. We want everything to be useful. So thanks so much. And thank you so much to Dr. Moniz, who our future child and adolescent psychiatrist, and Joyce Gonzalez, Loretta Arredondo, and Raul Gomez for our staff for helping us do all these presentations. And thanks so much. We will see you again. We have actually 3 offerings this month. So we have one next Friday, and then on the 4th Thursday. So look out for those if you liked this one. Take care, everybody. Have a good weekend. Bye-bye.